Assalamu alaikum. Good morning. Can you have the first slide, please? Okay, I think renal denervation has been a very controversial therapy, and in the last 10 years, we've seen different reports and different studies, and everybody was initially giving a lot of expectation, and as anything in life, if you set up a high expectation and you don't get the result that you want, you get disappointed, and that's what happened initially on the data of renal denervation. So my job is to go quickly, but at the same time, I think I have reviewed all the presentations of the other colleagues, and I think it's important that you guys at the end of this session, if you have any question in your mind, that we can answer it and help you with finding the answer. I think that's the most important thing. This is the fourth session of renal denervation in this meeting, and this also tells us a lot of things, because this is a coming back technology that people are adapting and start to believe in, and we'll start the session now. So only 23% have controlled blood pressure. So we know that we're not doing very well in our outpatient clinic. We know we're not controlling hypertension. We know that from all the data that we learned and from the literature, that we're not doing a good job when it comes to controlling hypertension. And we know how important hypertension is, because hypertension actually correlates with lots of bad outcomes: cardiovascular, renal, cerebral vascular, and ophthalmology complication. The need for the novel approach has been there for ages and ages, but recently in the last 2 decades, we start seeing the renal denervation. And I remember the first meeting, it was in 2006. We had it on Prague by Medtronic. I was on advisory board, and they showed us that small company that actually doing renal denervation and on US, and Medtronic was trying to buy and acquire that small company, and we were supposed to give the advices. What's their advices about is this is the therapy that we think it will work. The sympathetic nervous system is an important contributor to hypertension, and the antihypertensive medication actually fails to modulate that system, but there are some medication which comes with a lot of side effects as well. Renal denervation has emerged over the last 15 years, I'll say, and studies has been coming positive and negative with mixed result, and that's led to that there is some huge controversy about the efficacy of the therapy. But denervation of the renal artery has been proved to be effective, and especially when it was started initially, and it was a surgical denervation, then becoming now a catheter base. The current devices that we have in the market, we have the 3 devices. We have the Simplicity, which is radio frequency ablation. This is the 2nd generation, the spiral catheter. We have the Paradise system, the Record, which is the balloon-based with a cooling balloon and an ultrasound circumferential ablation of the entire artery. Or we have the ablative solution coming from Boston Scientific, and this is injecting alcohol into the wall. The 2 FDA approved are the Medtronic Spiral and the Record Paradise for use outside clinical trials. The European guidelines and of course the US FDA approved the 2 technology, and this is obviously comes after there is enough evidence that actually led it to be a class 2B recommendation as an indication. Who are the patients that we should refer to? I think the data divide between 2 groups. You have the off-med, which is the patient who are not on antihypertensive medications, and you have the on-med trials. The off-med, the efficacy of RDN has been actually examined in 6 randomized controlled trials on a drug-naive patients previously treated, and there is a washout period of about 4 weeks. The spiral hypertension was actually effective in reducing 4 to 5 millimeter compared with the sham control. In contrast, the reduced hypertension reinforced, which uses the injections, was actually not effective in the 24 hours. The efficacy of the drugs, the Radiance trial, which is the one for the ultrasound, RDN solo, showed a 6.3% reduction on the blood pressure. The reduction of the office blood pressure are also remarkably similar, with 5.5 lower systolic blood pressure in the RDN group. So basically, the consensus from these trials were telling you that there is almost, you are getting rid of one medications and you're having a similar effect as if you are giving your patient one medication when it comes to the off-med, from the off-med trial. The follow-up is the follow-up and the duration is small of therapy, but that's because you cannot actually leave patient without medication for a longer period on the sham group. The efficacy for the medication-resistant hypertension, all the early trials of the RDN was actually done on the resistant hypertension patient. So that's the initial studies, and this is blood pressure above goal despite concurrent use of 3 antihypertensive medications, aiming of reducing the blood pressure to less than 135/85 on the blood pressure monitoring 24 hours. The prevalence of in adults of hypertension, the resistant hypertension, about 20%, which is conclude to about 10.3 million. Those with resistant hypertension are more frequently characterized by demographic correlation of being black race, older age, male sex, and showing evidence of multiple comorbidities, vascular resistant dysfunction, metabolic abnormalities. This is all carries that these are a higher risk. And yesterday I was asked, why didn't you do it when you do the angioplasty for the patient on the same sitting? Because most of them are actually resistant hypertension and they have comorbidities. And that's, of course, not going to be possible. Patients with renal resistant hypertension have a twofold increase of risk of cardiovascular disease event compared with patients whose hypertensive is responsive to treatment. Patients with uncontrolled hypertension, despite treatment with 1 to 5 medication, efficacy appeared to be more variable. Of course, we had the hypertension 1, we have hypertension 2, and then the HDN3 came, and that's changed the whole thing because it was a negative trial. And the HN3 has all problems, and there's a lot of analysis of what happened in the HN3, but mainly as the registry trials came back in the last 3 years, the whole thing changes, and now we are believing that the renal denervation for resistant hypertension reduces blood pressure to an average of about 16 to 18 millimeter in about 6 months' time for people who are resistant to hypertensive. The duration of the RCT for resistant hypertension is limited to 2 to 6 months. The Global Simplicity Registry has reported sustained reduction of systolic blood pressure, as I mentioned, of 16.5 of blood pressure within the first 6 months. The RADIANCE program has demonstrated a similar reduction and very consistent reduction over the 3 years period. The ultrasound, the RADIANCE hypertension, a 3 arms randomized trial of renal denervation, it's the only head-to-head randomized comparison between the two systems. I'm not going to talk about that. I'm going to leave it to Dr. Nabil to present it. The Japanese have done additional meta-analysis, which actually confirmed the efficacy of the therapy and the selection. This is the whole programs that started since 2013 when we started the therapy, I personally did not stop. I was still doing the cases on selected basis. The combination of renal denervation and medication, especially the neuromodulator or the adrenocorticoid inhibitors, I think that's something that we're learning more about, and it's going to come in the future. The combination of both therapy, I think, there's a lot of data coming showing promising result that the renal denervation is part of the therapy with using the combination of the spironolactone and the other adrenocorticoids modulating drugs. I'm going to go for these questions because I think this is the most important questions that we need to address, and this is the most questions that people have in their mind when they actually ask about renal denervation. Is renal denervation a treatment option for untreated patients with hypertension? I hope by the end of this session we can answer these questions, or at least we start putting what we believe when and how we're going to actually answer these questions. Is RDN a treatment of choice for patients with hypertension that's fully controlled on medical therapy? How should renal vascular morphology for RDN be evaluated? What factors influence the blood pressure lowering effect on RDN? Does RDN reduce the rate of cerebrovascular event, heart failure, improve prognosis? Does RDN improve renal function, albuminuria, and renal prognosis? Does RDN improve cardiac function, reduce left ventricular hypertrophy, and ameliorate atrial fibrillation? Are there difference in efficacy and safety between the different RDN technique, radiofrequency, and ultrasound? What is the impact of RDN on quality of life compared with antihypertensive drug therapy? And which blood pressure metrics are the best to evaluate? Because each and single question actually is important to answer. So we agree, and we are writing the GIS consensus statement on this within 3 to 4 months. Hopefully, we will be releasing it as a first GIS consensus statement for renal denervation. And all these 10 questions are the questions that I've been raising now. Try to find an answer, and hopefully we can get some consensus on the answer for this question. Thank you.